So the real pathogenesis of reflux, and what Dr. Rama has already talked with you about, is that reflux increases the risk for pyelonephritis. Pyelonephritis can result in renal scar in some children, and at least this hypothesis that renal scarring can increase hypertension, renal insufficiency, probably not end-stage renal disease as we've heard, but the other issues that go along with hypertension and insufficiency. So when we look back to the original reflux imaging and therapy guidelines back in the late 90s, using this premise, ultrasound and VCUG were recommended after the first febrile UTI in all infants uniformly up to age of 2. And in general, the reflux guidelines thought that universal reflux management should be based on the likelihood for reflux resolution based on these nomograms that we've all seen and know. This began to really become questioned in the early 2000s, primarily with the Hoberman study and then multiple studies that followed that looked at ultrasound and VCUG and found that most children didn't indeed have reflux, and that when reflux was found, it was in general low grades. And they really began to question whether or not we needed to be diagnosing reflux, at least in all children. So using this premise, it goes back to the basics. Why do we need to know about reflux? Why do we need to diagnose it, and why do we think about treating it? It comes down to two issues: to decrease urinary tract infections and to prevent renal damage or scarring. So what are our treatment options? We have observation therapy, antibiotics, and surgery, and I'm going to take you through those today. And when we look at renal damage, there's no evidence that any treatment is effective to date, and hopefully this is where the future will be headed. So let's just start with observational therapy. What's the actual risk for developing a second febrile UTI if you've had a febrile UTI to begin with? When you look at the multiple studies that are out there, in mixed grades of reflux, that ranges from about 3 to 13%. And when you include only children with reflux, when you look at the no prophylaxis or the placebo arms of therapies, between 16 to 40% developed a second recurrence. That means that the vast majority of children, anywhere between 60 and 80 to 90%, will not develop another UTI in up to 2 years of follow-up after they've had one UTI. Well, what about antibiotics then? If you look at the combination of studies that was out before the RIVUR trial, what you found is that antibiotic prophylaxis conferred very little or no reduction in the likelihood for a second UTI after the first one. And in the bigger studies, the probably more well-done studies, you needed to treat anywhere from 14 to 42 children to prevent a second febrile UTI in just one child. And when the AAP looked at the conglomerate of all of this information with data in nearly 1,100 children, what they found is that even stratifying for each grade of reflux, the antibiotics did not work even in the highest grades. And then comes the RIVUR study. So where do we put this? It was long awaited. Most of us were very excited to see it come out. And the results showed that antibiotics work. Well, how well do they work? When you look at the data, 300 patients or so in each arm, what they found was that there was a 13% risk for a second UTI in the trimethoprim sulfa group compared to 24% in the placebo arm. So ultimately, the data concluded that, very similar to the last New England Journal study, you needed to treat 8 patients every day with antibiotics for 2 years to prevent a single febrile urinary tract infection. So if you think about just the sheer number of pills, that is, it's nearly 6,000 pills to prevent a single urinary tract infection, which may or may not even be febrile because they combined those two in the study. If you think about how many pills it needs to treat a urinary tract infection, obviously that's far less. So when we go back again to our basics, observation shows that most children aren't going to develop a second UTI. Antibiotics help, but not a lot, and you have to give an awful lot of pills to prevent even a single febrile UTI after that. Well, what about surgery? When you look at the RIVUR study, back to the original IRS study, Overall numbers of urinary tract infections in the surgery versus the placebo group were not different. However, what they didn't really tease out at that point, and that has become more clear since then, is that febrile urinary tract infections did diminish. And that's important with data that I'm going to show you, that the febrile urinary tract infections are the ones that I think we need to be most concerned about in terms of renal damage. And these numbers of reducing the number of febrile urinary tract infections have been shown not only in IRS, but now in multiple studies, whether it's open surgery or deflux that successfully corrects the reflux. So that brings us down to renal damage. If urinary tract infections are not a big issue in most patients, and we can focus our attention on those that they do happen to be a recurrent issue, what about this group of patients that has renal damage? Because that's the other group that we want to think about, and they may or may not be the same. So when Dr. Snodgrass was on the guidelines panel, it became very clear that the literature out there was not very replete with knowledge about information with reflux and scarring. And in fact, the results were mixed. Some showed that there was an issue with reflux and scarring, others showed that there was not. When the reflux guidelines did the meta-analysis that they had, it was based on only 4 studies, which did show an increased risk for scar in children with reflux, but most of these studies had small numbers of patients and were subjected to some selection bias in which children did or did not undergo DMSA scanning. So that led us to start a prospective observational study. So just like we've done in hypospadias, we started a protocol and kept a prospective database in reflux with the sole purpose of trying to determine how many kids with reflux had renal damage. So we decided in our protocol that we were going to get a DMSA scan 3 months or more after their last urinary tract infection, so that we weren't identifying acute injury so much as what could be longer lasting scars. This is our data collection sheet. It was just a page that we developed which looked at their reflux. It looked at their number of febrile and non-febrile urinary tract infections that they had at baseline at the time they got referred to us, whether or not hydronephrosis and the size of each kidney on ultrasound, and then we graded the DMSA scan using the exact same grading system that the RIVUR trial used when we borrowed that from them, and looked at their toileting habits. And we did this in consecutive patients, so every patient that was referred to us that had either a febrile urinary tract infection, reflux, or both, we recorded this information in. Well, what did we find? So overall, we had 565 patients, of whom the majority were female around toilet age. So this is exactly what you would expect in a group of children referred for urinary tract infections. And we had about a 20% rate of infants that were in there, so that we could stratify all of these. And of these 565 patients, what we found was that the vast majority did not have renal damage. Okay, and this was a large group of patients who had multiple urinary tract infections and reflux of all grades, and the majority of them had healthy appearance to their kidneys on DMSA. However, there was a fair number, 19%, that did have damage that we could see, which was either focal scarring or decreased function or a combination of both. So our goal then was to determine the prevalence of renal scar, and we did that. Here's the number. But we also wanted to look at the individual risk factors for scarring so that we could help stratify this. So what about grade of reflux? Well, as you can see, the grades 1, 2, and 3 have a risk of scarring. They can have renal damage, but overall that's low. And that jumps way up for grades 4 and 5. But even with grades 4 and 5 reflux, half of the children have absolutely no damage on their baseline DMSA scan. And then when you look in terms of urinary tract infections, the ones that have multiple infections do have a higher risk for scar, but even amongst those, the vast majority have no damage on DMSA scan. But because there's this relationship of, age, and some of the younger kids have higher grades of reflux but may not have had as many urinary tract infections, how do you untangle this? Well, again, just like we talked about earlier, this is where you can use statistics to try to help untangle this. And there's a lot of information here, but at the end of the day, what it shows is that every year older the child gets, the higher their risk is for having something that we identify on their DMSA scan. That grades 4 and 5 reflux are huge risk factors for seeing damage on DMSA scan, and that if you have 2 or more febrile urinary tract infections at the time that you're being seen, that's also a risk factor. Okay. What we didn't find to be a risk factor was bowel and bladder dysfunction. And we're not the only ones that find this. When you look at the results from the RIVUR study, they're the exact same. What else did the RIVUR study tell us in terms of renal scarring? It shows us that for the most part, most children don't have renal damage, at least not at study entry, but that unfortunately, even with 2 years of very tightly controlled antibiotic prophylaxis, we did not see a decrease in that rate of renal scarring at the end of the study period. And unfortunately, the New England Journal didn't have the authors comment more on this patient population, which I think it really needs to. These are the children that we're most interested in. Were they the ones that got the recurrent urinary tract infections, and why don't we see a difference in that with the two groups? But a long story short from that, at least what we see is that antibiotic prophylaxis does not prevent new renal scars. In general, we're trying to see about renal scarring. We found that. We've shown you, we've been able to identify the risk factors for renal scarring, and they were similar in our prospective observational study as they were to the randomized control trial results in the RIVUR study. But what we didn't expect, but came out of our database, was that this was a good method now where we could risk stratify these reflux patients, and it actually ended up impacting our treatment algorithm. So our hypothesis then, as we were in evolution of doing this study, was that a late DMSA done a few months after the urinary tract infection could help us identify those patients that have renal damage up front that then could go on to develop additional renal damage versus those children who don't have renal damage who maybe have less risk for additional damage even if they happen to get a second or third urinary tract infection. This is based on some evidence that was in existence already as we started this endeavor, with a cohort of a large number of patients that did long-term follow-up DMSA scans, and what they found in a very large number of patients was that only 5 children developed new renal damage on DMSA done several years after their initial DMSA after febrile UTI, and the vast majority of those 5 patients had multiple febrile UTI recurrences. So this then led us to think that we should be doing more therapy perhaps for these children that have baseline damage and less or no therapy for those that don't. So let's take this through some cases that would walk into our office. These are examples straight from our database. So case number 1 and case number 2 are both 3-year-old females. They've had 3 febrile urinary tract infections over a course of a 2 or 3 year period, and both of them have absolutely normal sonograms, so no hydronephrosis, no renal size discrepancy. The first one has grade 2 right-sided reflux. So all of you can think about in your mind what you might do in this scenario. Well, we got a DMSA as part of our protocol, and what we found is that at least in this child, she had 35% function, so diminished function on the right with multifocal scarring. And so in this circumstance, we recommended deflux or surgery to then correct her anatomic issue and hopefully reduce her risk, at least based on data showing that febrile UTIs statistically improve after successful correction of reflux, so we recommended surgery for her. On the other hand, the child with grade 3 reflux on the right, with a similar story, had an absolutely normal DMSA scan with no focal scars, no renal damage on either side. We've stopped her antibiotics. We have observed her now for many years with treatment of her bowel and bladder dysfunction if she has that eventually, and what we found is that she has not developed any further issues with urinary tract infections or problems. So this drastically changed how we might have thought about these children just a few months or years earlier if we hadn't have had this information from their DMSA scans. And if she did develop a second or third or fourth urinary tract infection, then that would be certainly reasons to think about either repeating a DMSA scan or looking into a VCUG for her so that you could treat the reflux for her recurrent urinary tract infections. For this child, it wouldn't be for the DMSA issue. So you guys might ask, well, what about the new guidelines? Because the AAP does not recommend a DMSA scan after the first febrile UTI. They only talk about renal ultrasound. So how does this work in? And I guess what that brings up is the question that was asked earlier, does a renal ultrasound help us predict damage? So fortunately, we have that data from our database to let you know about that. So clearly, if there's an abnormality on the renal ultrasound, which is any degree of hydronephrosis, including pelviectasis or SFU grade 1, or renal size discrepancy of a centimeter or more, these children have a statistically significantly higher rate of having damage on their DMSA, double, okay, 30 versus 14%. So an abnormal ultrasound can be an indicator that these children may need some additional evaluation. And this is particularly true for older children. So we stratified it for our younger children with the guidelines and our older children, and we were shocked to find that 60% of them with any sort of renal ultrasound abnormality had damage on their DMSA scan. But the real question then is, what about the children with normal ultrasounds? If we agreed that the children with abnormal ultrasounds should undergo additional testing, what about these kids with normal renal ultrasound? What we found is that unfortunately it has a very low sensitivity for picking up renal damage, and we're not the only ones. This number of between 30 and 40% sensitivity is what's found consistently in the literature. So ultrasound alone is not good enough to pick up on renal damage, and there's a very high false negative rate of 19%, meaning that 1 out of every 5 patients that has a normal renal ultrasound will have damage that we're missing if that's the only study that we do. When you stratify this by age, however, it becomes a little bit different, because even though these little infants are the ones that get these high fevers and they're getting admitted for IV antibiotics, it's the infants who don't tend to scar their kidneys, whereas the older kids do. So as I told you, the RIVUR study, and we showed that the older the age was, the more likely that we would see some sort of abnormality. So it actually misses 1 in 4 children who are over the age of 2. And so I think that's an important thing to keep in mind as I tell you what we do now as our evaluation for febrile urinary tract infection. But before I do that, I wanted to just ask why ultrasound and DMSA is a combination as opposed to ultrasound alone. Well, that's just what I showed you: poor sensitivity and a high false negative rate to pick up on renal damage in that group of patients that maybe intervention could potentially offer some help, although we don't have data to show that yet. That's the group, hopefully, that we can get that data in. If we did VCUG in all of these patients, well, I think it's become more and more clear that we're overdiagnosing in reflux in most children who aren't going to even get a second febrile urinary tract infection and who don't have any renal damage to speak of when we see them. So if we use DMSA scan as then our gold standard to try to help pick up on somebody who has some baseline damage, and then VCUG for those who are going to go on to develop a second urinary tract infection, at least for right now, that's our gold standard test to help identify renal damage with minimal radiation. It's about the equivalent of an IVP, less than a CT scan, and probably less direct gonadal radiation than a VCUG itself. So that's why we use that as our initial screening test. So how do we synthesize then this evidence from multiple trials? Well, at our institution, if they're younger than a year, if they have an abnormal ultrasound, they're going to move on to a DMSA scan. And then if their DMSA is abnormal, we're going to get a VCUG. And I can show you the numbers if we have time later, but this helps to identify those children with reflux that we might want to emphasize treatment in. If they're more than 12 years of age, though, that ultrasound alone is not going to be enough. And so those children, we do an ultrasound acutely to rule out something that perhaps never got diagnosed, patient, for instance, or ureterocele or a UPJ. And then they're going to go on to get a DMSA scan about 3 months after their original urinary tract infection. And they're going to get a VCUG if that DMSA is abnormal, which is about 20%. So how this works for us is then DMSA is going to help us identify those patients who should undergo a VCUG for renal damage. And of course, you can also use that second or third febrile urinary tract infection as your other indicator for that. And then our thought was, and hopefully what we'll be able to show with time, with your help, and others can hone in on this, is that maybe a DMSA-based assessment can help identify the patients who are most likely to benefit from therapy, so that we can then promote reflux resolution in those with either surgery or deflux with renal damage, and decrease our intervention. So take off the antibiotics, don't do additional studies in those who don't have renal damage and who never develop another urinary tract infection. So what this means from an evidence-based standpoint for us is that we used our prospective study to not only give us the question that we sought, which was the prevalence of renal scars in these kids with reflux, but it also helped us to look at the individual risk factors and tease that out, and then gave us an evidence-based imaging protocol that we use, as I just explained to you. So what we overall learned from this experience, along with our hypospadias, is that we can use our prospective data to help us hopefully manage patients, risk stratify patients, and this is something that is so exciting to hear about centers that are trying to apply this to the many aspects of things in pediatric urology that we just don't have all the answers for. So let's stop looking at surgical outcomes, think about what are the basic indications for why we're treating this condition in this patient, which for reflux is UTI recurrence and renal damage, and focus our studies and our future directions on those things. So we learned that reflux does increase the risk for renal scar, but overall that risk is low, and it's low for grades 1, 2, and 3, even 3 reflux, and jumps up for grades 4 and 5. What we don't know yet, and hopefully what can be determined with time, is if we can do something about reducing or stabilizing that renal scar risk. And I think if you use our data to say that we can reduce statistically significantly those febrile urinary tract infections, and knowing that it's the febrile urinary tract infections that impact their renal scar risk, hopefully that's something that we can do, but still needs to be shown. Okay, any questions?
Thank you, ma'am. You've clearly brought it to light, the top-down approach. Any questions?
When you showed the 2 experience of patients, you showed patient 1 and patient 2. My question is, you spoke about bladder bowel dysfunction in patient number 2. On the first patient, if you had bladder bowel dysfunction, would you offer surgery along with the treatment of bladder bowel dysfunction, or would you give a window period when the bladder bowel dysfunction is treated and then offer surgery?
So I think there's a lot of questions about bowel and bladder dysfunction, but our data and the RIVUR data have consistently showed that bowel and bladder dysfunction is not a risk factor for renal scar. It could be for cystitis episodes, but our data also shows that when you just look at the various components of bowel and bladder dysfunction, constipation and overactive bladder symptoms aren't a risk factor for febrile UTI recurrence either. Infrequent voiding is. But how do you make a non-toilet trained child void more frequently? You know, I don't think any of us have the answer to that.
So my question is, would you offer surgery even when the bladder bowel dysfunction is still under treatment, or what would you do?
Absolutely. I mean, she's got renal damage that's there.
You just go ahead and do that.
I think she needs to be fixed. That doesn't mean you don't also concomitantly offer and discuss bowel and bladder dysfunction.
The other question I wanted to ask you is, we do see patients not with renal scarring, sometimes a kidney that looks a little smaller. But you know, what do you do in that? Would you consider that as a sign of renal damage, or would
So we looked at that. Our size cutoff, we just used 1 centimeter because it was an easy number to remember. You have one kidney that's 6 centimeters and one that's 7 centimeters. So that would be considered in our study as an abnormal renal ultrasound. And those children did have a statistically significantly higher risk of having function and scarring abnormalities on their DMSA scan. So I think it's important. But it's also important to know that early on, when they first develop their urinary tract infection, you may not see that. Serially, with time, ultrasounds actually do probably a better job of correlating with DMSA scan, but that's over a many-year period when you see that size discrepancy as the child grows. And so I don't think we want to wait for many, many years to use ultrasound as our proxy for that.
Yes, Sanjay.
Dr. Bush, thank you very much. I think you have shown what you spoke in the first talk about maintaining a database and then making decisions based on what you find in your database. I just have a question to ask about how, now there are 2 sittings here. One is a hospital-based sitting, which is all your data. But I think the pediatricians and the primary care physicians probably see a large more number of less sick kids. So how do you reconcile this? Because I think isn't it that we are looking at 2 different types of patients? We are selecting a group that is more likely to have problems when we look at it purely from a hospital-based point of view.
That was a great point. So this is a referral-based population, but when the pediatricians decide to refer is up to them. So we had a very large patient population that was first febrile UTI, and they got sent early on. But then we had others that had come with multiple urinary tract infections, and how do you reconcile that? Well, that's where you have to use statistics to try to help with that. Now, whether or not this information would apply to a patient-based sample is, impossible for us to know, but when you look at the synthesis of evidence that's out there, all of our numbers are very similar to what you see. So if you just take the Hoberman study, for instance, where they did a top-down approach, how many that come in with pyelonephritis have acute DMSA abnormalities, that number's 50%. How many of those will then go on to develop chronic renal scarring, that number's 25%. That's very similar to that 20% number that we see. And consistently across the literature, when you see that consistency, that's where evidence, I think, really becomes more clear. Yeah, we have, some have, that's right, and these are not hot, they were all referred to us from their pediatrician, so this was at their time of referral with various stages of reflux. Some were sick, some were not, etc.
This DMSA negative patients, what percentage of them, is there any study to show what percentage have vesicuritic reflux? DMSA, urinary tract infection, DMSA done, positive.
I can show you that data if you pull up my slides.
Where there is a negative, how many have reflux? No, see, there's a lot of concern is now there that based on the recommendation that only you will do an MCUG for a DMSA positive,
Correct.
you might miss quite a significant number of refluxing children and ultimately renal scarring. This doubt has been expressed again by the American Society of Urology in the May.
That's correct. That's the theoretical problem that people bring up, but there's very little data that shows that children who have a normal DMSA scan problems in the absence of a febrile UTI recurrence. There's no data that says that somebody has a normal DMSA scan will develop renal damage without another febrile UTI. So you have a way to find those children that might go on to develop problems.
Yeah, last.
Mohan from Davangere. With your DMSA scan in the second year of life, is it possible that you're capturing a photograph of a person who's already had reflux grade 4s and 5 when you're catching that scar? Because these are referral patients, you don't know their condition before.
Correct.
And the second part of this is the last place where I worked, we found it very difficult to get through our pediatric urologist with the relation to radiation doses in DMSA, and he was very adamant. And how are you going to follow these up with repeat DMSAs? Again, you're increasing your radiation doses in these smaller children.
So that's why we chose the 3-month DMSA mark, so that we weren't doing 2 DMSAs like the traditional top-down approach where you DMSA everybody and then DMSA 6 months later. We chose the 3-month mark to diminish that specifically for that reason. Of course, we don't know when that damage occurred because we only have the baseline information, but we know how many urinary tract infections they'd had at the time that they were sent in. And we found that that relationship for grade 4 and 5 reflux was separate from their relationship from recurrent febrile urinary tract infections. And those are both independent risk factors, and they're both important.
But could they still have higher grade refluxes and which have come down by the time they've come to see you? And that's the dysplastic element causing your damage, which would mean that your procedures would not actually change anything of their course, because we don't know that initial thing. As you said, you don't have a DMSA before or an ultrasound before these kids get
We do on some of the children who came before just with reflux from, say, prenatal hydronephrosis. We have some of those that had never had a urinary tract infection, but the vast minority of those had any renal damage. Some of them do, and we can follow those with time. So it's really that prospective longitudinal information that I think will help answer those questions.
Thank you.
Thank you, ma'am.
Thank you.